Hello, this is Heather Jessup and Ann Heckler-Vouch with Journeys with PDA, and we are here today to discuss assessment with a friend of mine who I've known since both of our children were one and in the same gymnastics class. This is Dr. Gokce Ergun. And I'm going to let you go ahead and introduce yourself and tell us about your areas of interest, and then we'll take it from there.
Sounds great. Well, thank you, everyone, and thanks for watching. And I'm very excited and happy to be here and talking about autism and assessment for Journeys PDA. So as Heather mentioned, my name is Dr. Gokce Ergun. I'm a clinical psychologist and an associate professor at the School of Professional Psychology at Wright State University. Since I started being interested in psychology, I've been interested in neurodevelopmental disabilities and specifically autism spectrum disorders, prenatal alcohol and drug exposure, ADHD, learning disabilities. And my area of expertise is specifically on diagnosis, assessment, and then for some areas on treatment of neurodevelopmental disorders as well. And currently I'm teaching at Wright State University and I'm also supervising. And I'm happy to be here to talking about some of the more specific areas that I would like to focus on today. And yeah, I'm very excited to be here.
Well, thank you. We're very excited to have you. I think maybe just to start off, we should probably start at the beginning. And I know that a lot of our families that Ann and I work with, the kiddos, especially PDA, people who are suspected to have PDA, have kind of an atypical presentation of autism just to begin with. And so they confront barriers just constantly because a lot of these kiddos, they're social. They make eye contact, you know, they do all of the neurotypical kinds of behaviors, and it's very, very difficult for parents to express those things to an assessor and have an assessor kind of go, well, it doesn't quite fit. So maybe if you could help us maybe understand what the barriers are and then how to overcome those barriers.
Definitely. And you're very right on target that our children, our autistic children have a very heterogeneous presentation, as we all know, meaning that not one child is going to present as another child in terms of both of their symptoms, the severity, the things that they can do and accomplish, meaning their strengths. So overall, I think we as psychologists and all professionals working with autistic children and their families, whether we're approaching from a assessment perspective or treatment or consultation or advocacy, I think that's, first of all, what we need to understand is, of course, what really that spectrum means. And spectrum doesn't mean just to throw all the kids in that same, ball and then just kind of like saying everybody has a similar, presentation. It means that every child is unique. So now I'd like to talk about what are those areas that can be unique, but also can pose as barriers as the families embark on the journey of getting their children evaluated for the hopes of getting some answers, as well as a diagnosis, but most importantly for understanding their children, so they can just start up their interventions and start having a meaningful a life and success at school. So some of the barriers, so when a family suspects that their child might have autism and they go to usually it's going to be a clinical psychologist, maybe at the school it can be a school psychologist or a neuropsychologist for an evaluation, because those are the individuals who would be qualified to conduct such evaluations. Then some of the barriers would, first of all, would be around language. Yes, some children, of course, will have full, complete language development, maybe after some early interventions of speech and language therapy, but some children will still be struggling with language skills. So that's first and foremost what we need to evaluate in the intake as to where those language skills are. And I'll talk about like how we can address those. Another area of difficulty could be what we call joint attention deficits. So as you know, probably all of the viewers, you know, if you have a, autistic child, you would probably know if that's one of the, if that were one of the symptoms, is that for joint attention, it means that when you are showing something, for example, a book or a toy, we would, show to the child, and we automatically expect that the child also shows an interest in what we are showing. And that's called joint attention. The parent and the child joins in the activity to do something together, like play. So that's kind of like the basis of play and interaction. But that doesn't naturally happen with our autistic children. So as a result of that, think about the situation. If maybe some of you have observed the evaluation, the assessors usually ask a question around, like they bring a booklet, they show some objects, or they have some manipulatives that they want the child to move around and do things around with. So then the child might not be interested in what we're showing, right? Because they do not show that joint attention. They might be interested in another thing that we have in the room that could be more interesting to them, more reinforcing for them. So they could go to that, but not come to us. So what does that mean? That means they cannot complete that task. That means they cannot complete that specific measure. And at the end, they could be labeled as untestable. I cannot test this child. I've heard that so many times from parents saying that, well, we've tried a couple times and we can't get a diagnosis. We can't figure out what's going. We have other diagnoses. The schools provide us the interventions already, like my child is already autistic and has been diagnosed, but we don't have the official diagnosis because they couldn't be tested. Another barrier would be behavioral difficulties. So behavioral difficulties would be things around disruptive behaviors, such as, it could be throwing things away. It could be, very heightened anxiety around being in a small room. And a lot of the examination or testing rooms are going to be small. And they could engage in repetitive or stereotypical behaviors. And those could also get in the way of testing because we expect that they sit and do what we ask them to do. Well, that could be very difficult because we're actually placing a demand, and lots of demands, saying you do this first, then we do this, and we give a break and we do this. It's all under control of the assessor. And it's like the child has no control over the situation. So that's very difficult for a subset of children who do resist that being given directions to, being placed demands, on themselves. So then a lot of the children, what do? They leave the room. They want to go as soon as possible. They can bear and, for only a little bit, and then they go. Well, what do we see then as assessors? We usually see they're avoiding it. They're running away. We see the behavior, but we have sometimes hard time understanding the underlying function of it. Why do they want to leave? And then we just see the disruptive part of it, but not the underlying piece. And another problem or difficulty could be sustained attention, which is maintaining the attention for a period of time. So a lot of the tasks, they could be interesting, but not all of them will be as interesting to the children that we're testing. And therefore, they will not be able to keep their attention long enough to complete a task. So if you tell a child, and a lot of our tests do have that, now I want you to solve these problems as fast as you can and put a slash on this, object, or just like a picture of it, which also resembles this one here. So they had to do it like in 2 minutes, for example. And then we have a stopwatch. So the child goes like, oh my God, I need to do it this fast. What is it? It's, increasing that anxiety that's already there. So again, I'll talk about how we can, play around with that piece. But just even understanding that the testing situation, not for autistic kids, but for anyone, think about yourselves. Like if somebody, you need to be all tested right now because somebody has a brain injury or something. just we're in this some in a room, in a small room with a stranger we haven't met before, and these are children. That creates anxiety, time limits, lots of demands. Everyone would want to flee actually, but as adults we sit because we're adults. So just understanding the nature, unnatural, part of this process, should hopefully also help, both the parents and the children and the clinicians, hopefully, to understand and then to gain a much more, empathetic, orientation, towards the children. So those are some of the, major kind of like barriers that we have. And as a result, then we could just, the psychologist might say, well, I'm not able to test your child. They just didn't stay in the room. That's all we hear. But, we really don't really hear the other pieces that, I've just kind of talked about.
I think in our case, with my son, we were, I don't want to say lucky, but he kind of likes the attention, when he goes to have the assessments done. So that's never really been a problem for us. But I know, Anne, your story is just a little bit different there.
Yes. Yeah, it's interesting as you were, honestly, everything that you said, it was like a check mark for my son. Because, and I feel like in our assessment situation and my concern for other families with kids that are suspected of having a PDA profile is that the results will not be accurate because, like you said, not shared attention. For example, my son would be the one that's looking at everything else in the room because he wants, he notices everything and he kind of wants to explore what else is available and not necessarily exactly what you want him to look at. So there's the first one. The second one obviously is behaviors, the demand avoidance, you're telling him what to do, therefore I'm not going to do it. It's going to be a no. It's going to be a maybe throw things, the objects that you said you want them to manipulate or do things with. It can be leaving. All those things happened during his assessment. The sustained attention, a lot of our kids also are diagnosed with ADHD. So even that, coming into play, plus just the demand of sitting and doing what you want them to do. Like you said, the timer, everything that you said describes what my son would not want to do in the assessment. And so therefore my concern was when we got the results is that I felt they weren't accurate. I wasn't saying my son wasn't autistic, but I would not in any way, shape or form say he's a level 3. And those people that have met my son since would, they're like, what are you talking about? But because he was so against everything that was going on, that's why it appeared that way. So the concern for me was, and is, I've been an educator, I have a degree in education and I've been a parent educator. So I have that background. So I knew walking out of there, I don't need to take what they're giving me as far as suggestions of what to do, because I know that that's not accurate. My concern is for the parents that don't know that and they walk out and they take exactly what they've been told to do. And for our PDAers, it's not necessarily what kids with a different, presentation of autism need. So in this instance, why I'm so excited that you're talking with us today is what are some accommodations or modifications that you either, suggest or have made yourself to accommodate for some of these things that our kiddos, particularly with, a demand avoidant profile, what changes can you make so that you get a more accurate end result?
Definitely. Well, first of all, thanks for sharing your experience with your son. And definitely, when you mentioned about, okay, what about the accuracy of results? That was something like when we talk about maybe the assessment process in general that I also wanted to highlight that, but now that it's timely, I will do that. Validity, that's what we call the validity of any assessment, is extremely important. And of course, we're all trained psychologists to pay very much attention to that piece. But again, there are variations and approaches or attention to that as well. So overall, once a psychologist conducts an evaluation, we have to assess the validity, which means the accuracy of each of the measures that we give. So when we write up a report, we have to indicate there that results of, for example, if you did an IQ test, we have to indicate at the very beginning paragraph, that's what I teach in my classes, that's like 101, we have to indicate whether we think as a clinician, whether the results are valid or not. And how do we determine that? Well, some of the tests have those embedded in them, some of the rating scales. I'm sure as parents, you have completed a lot of rating scales. Some of those rating scales have a built-in validity scales that when we put them in the computer, the results, it gives you a result like, yes, this parent has consistently responded to all the questions. And they have not, tried to fake things as too good or too bad. So we have some ways to, and psychologists are trained to interpret those. But on the other hand, we can determine validity of a test that's done on a what we call performance-based measure, just like an IQ test, which is you sit down together with a child and do a face-to-face testing. So how do we determine the validity and accuracy of that? Well, all of the things that I've mentioned, as a good psychologist should really be paying attention to all of those pieces. And all in all, at the end, we should answer this question. We had attentional difficulties. We had some behavioral problems. So despite these behaviors or limitations or barriers, do we think as a psychologist, do we think that the results still reflect what they can do or reflect their true estimate in that specific area? So let's say we came up with an IQ score, okay? And to give you an example, I'll say this. I was evaluating a child for a learning disability and also had comorbid ADHD. The child was on medication and came, and we usually do our IQ test in the morning. So we started doing the testing. The child was very, very impulsive and very active. And usually when they take the medication in the morning, by like 7 or so, by the time they come to us at 9, things are pretty, settled down. That wasn't the case. And at the beginning, I always ask, is medication taken? And then the parent said yes. We move forward. The test is done, but it was extremely hard. I was working with one of my doctoral students. We watched how things went and we scored. Scores we looked at immediately were very low. They were below the average range. Well, what have I seen so far for this child? What I've seen is that this child really does not have cognitive issues from all the history and all the things that I've seen. And I said, there is something wrong here. And then we went back to the parent after the testing session and we said, we'd like to discuss something with you. These results are very, they don't seem to reflect your son. They don't seem like him. We're not really sure what went on. He was extremely hyperactive. I know he has hyperactivity, but medication usually, you said in the intake that it helps. Mm-hmm. And then she came back and said, Dr. Ergun, I'm really, really sorry. That morning I forgot, but I felt really embarrassed to tell you that we forgot. I said, well, first of all, please always feel free to, share with me. It's okay. We could have rescheduled. Yes, so we did it. So what do we do with those results? We threw them out because that's by no means. But then we couldn't do the same test due to practice effects. So we found another test and did it. And this time with medication for sure. And it was like night and day. And we got average IQ. So this what I'm trying to highlight as the accuracy and the validity of the results. So we always have to continue to be vigilant and not just really rely on like what we just get, immediately. So just wanted to depict that as well as an example. So back to your question on what are some of the accommodations or modifications that we can do if we see a more atypical, presentation that might not fit into our general, testing, protocol, which is one size doesn't, fit all, right? Approach, and then our children have all individual needs. So then we need to think outside of the box and of course be very flexible as assessors. So if our child, I'll start with this same piece. So if our child in the intake was having language difficulties, of course, we don't want to give for example, an IQ measure that is all verbal, because what we're really disadvantaging them, and we cannot really get to their actual cognitive skills. So then what we need to do is also choose a nonverbal cognitive measure or an IQ measure where all they need to do is point to things. So if we show them certain categories, we can say what comes next. So all they need to do is understand very simply, and then they show. They don't really have to talk. So there are multitude of tests like that psychologists are trained in. That's one of the classes I teach on cognitive assessment. And so we could choose a test like that. But then you might say, what about those manipulatives? Some of our children, some of our autistic children have fine motor difficulties, right? So they might have dyspraxia and fine motor issues. So then if they use their hands, they're still going to be disadvantaged. Okay, then we can choose another cognitive measure that does not require them to do things like puzzles and things with their hands, because we don't always need them. All we need to understand how they problem solve, how they think, right? How can they understand kind of like that abstraction and those type of things. So that could be enough for us to understand their cognitive functioning and to decide if we're seeing an intellectual disability that's accompanying or not. So that's one way to approach for the language piece. What can we do for that joint attention? First of all, we need to engage in very careful rapport building. So at the intake, that's very important. Intake is our interview where we first get to know the family, the child and the parent, right? So we need to spend good time asking about their hobbies, their interests, their specific interests, what they like to do. And then we could provide some what are called warm-up sessions. So warm-up sessions is not when you start testing immediately, but you just kind of spend time together. It can be in a playroom if you have a play therapy room, or it could be in your office if you have some toys, some things that they could be interested in. Sometimes children will not be interested in the things that you have in your office. So you could even ask the parents to bring some things that they're interested from home. And then that can be integrated into that piece. So that kind of like eases an anxiety first, makes them more familiar with the surrounding. So I'll be kind of like talking about a case, and I think I can a specific example, and I can talk about how I applied all of these, during that time. But that kind of like helps them to understand, because a lot of the children also think that they're coming to a doctor's office, they're going to have a shot, they're going to be hurt. So that kind of like eases them into the situation that we're kind of doctors, but not like that kind of doctor. And then we're just going to do some fun activities together. That where they're not going to be forced into a corner, like maybe in a physician's office and so forth. So kind of like helps out, with that piece. And another one is we could do shorter sessions. Usually our sessions are around 3 hours. Well, that could be pretty long for our child who kind of gets fed up, pretty easily. So we can keep them like 1 hour sessions. Yes, it's going to be longer. And maybe that's something that you would need to talk with your provider, saying like, can we have some extra sessions? And some of you might say we can't do that because of insurance, because some of those sessions we didn't bill to insurance. It was just to make sure that we can complete it. But I think we owe it to our clients who actually need this evaluation. And so that's a conversation that I would suggest that parents in that position, if they would like to have, or maybe even find a provider who approaches assessment this way, and not like one who would say like, no, we can only do 2 sessions and we'll be done. So then maybe you don't choose that provider, and maybe you choose another provider. So this could be something that you can ask in the when you take an appointment for an intake, right? So the rapport, shorter sessions, and engaging them. Another one is adjusting the environment of the testing environment, which is kind of like our, office or our room. So a room, again, we may not change our room totally, but I'm sure in every office or practice or hospital, there is one room that's pretty, plain, and maybe like a group room or one-way mirror room, one of those where we can design it. If we cannot change our offices, but where distractions are limited, because autistic children also tend to be very easily distracted, one, but also easily overwhelmed if we have all of these paintings everywhere, pictures, so many small things around. It could be like kind of way too much. Okay, could even like work to dim the lights if the lights are kind of like bothering. If it's an office that's close to a very crowded area, we could choose one that's not as crowded. So anything to minimize the distractions and decrease that sensory overload would really help them out and not to dysregulate their system easily. Okay. Another one is, we could provide some fidget toys or toys that, they could have a preferred sitting, like one of those exercise balls, if that kind of helps out for them to sit and not escape because it's more soothing. We can do that. Again, work with the parents. Parents are the experts on their children. Let's give an example. I was talking about something with my daughter, and Heather knows my daughter, and she said, "Mom, you know me much better than I know myself." So I think we are with them 24/7. We know our children the best. And that's one line, something that I say because I truly believe in that. To every parent, I say, you are the expert. I need your help. I need you to help me to figure things out. Yes, I'm the professional. I know what I'm going to do procedurally, but you are the expert. You need to tell me which snacks your child likes. You need to tell me what toys they're interested in. You need to tell me or share with me if the child is young. If they're older, they can tell you too, but the parents are, the best on that. So preferred seating, limiting instructions, providing the fidget toys. So just really arranging our environment would help out with that regulation. And that could kind of like help out for them to engage more in that joint attention. And that could cut down on some of the behavioral issues that we might also see. Another thing that's really helpful is providing visual checklists. So when they come in, we could have 15 tests, little subtests to do. And you're all probably familiar with subtests and things. You probably read all reports. So those are all little activities or little tasks that we need to do to complete a measure. A measure can be an IQ measure, attention measure, memory measure, and things like that. So let's say if we have 10 things that day to accomplish. So we can just do a paper, like a Word document or something really kind of like fun. And I usually put in there some things that they like. If they're really into dinosaurs, I put like different, dinosaur pictures on it. And I do one task, 1, 2, 3, so that they visually see what they need to accomplish. Because some of our autistic children, they are really drawn to that structure, to that transition. They want to know what's coming next. That creates that anxiety. If they don't know what's coming up next, it could be too much. I work with one child who really wanted to know what was the next thing that's coming up. So once we were done with one, we took a little, like a very small break, and we did a checklist on our visual schedule, said, you did this, and here is your sticker, you can put it on there. So, and then he said, so what's coming next? So next, then we're gonna do, you do a brief explanation of what's the next thing to do and say, okay, are we ready? So giving that cue and making that transition smoother than, okay, this is the next thing. So giving the control back to them and having that balanced versus the assessor being in control of everything. That doesn't really sit well with some of our children. So when they feel that they are part of the process, but not being totally led in that process, and if they can feel that, it kind of like makes them more collaborative in general.
Just a quick question on that one. What happens to the validity of the test? If, say, for instance, a child was presented with, a checklist like that, and there were different orders that they wanted, like maybe their control piece is like, I don't want to do this one yet, but I want to do this one. I mean, does does that kind of thing affect the validity of the test? Or is it perfectly okay to, let even the child have that piece of control in what they're going to do next?
Yes, definitely. That's a great question. And I think that's also a great thing to discuss with your psychologist as to is that, something that we can do. Sometimes we can do it, sometimes we can't. And I'll tell about a situation where we really can't do anything. So I'll just tell both of those. So one, a lot of the IQ measures or face-to-face measures, they have what we call standardized testing, okay? Standardized procedure, which is you start with the subtest, you need to go through this sequence, and you can't sway from that, okay? However, all of the measures do provide in their manuals a section that says, if you need to get out of the standardized situation because your child that you're testing has some needs, and based on that, then you can do that. So all of the tests do allow us to do, but there's a rule. Whatever we modify, whatever accommodations we add, whatever we change, we need to indicate that in the report. So the person reading it, the other professional reading it, we really need to understand that this was not done on a standardized situation. But then at the end of it, okay, so let's say, and I'll give you an example. We have a test, for example, one of the IQ measures where we ask about digits. So we say, I'll say some digits, and after that, I want you to repeat after me. So it's kind of looking at that short-term, memory and attention. So we need to do that one first. Then we need to do the backwards because we asked them to say it backwards. And then we mix it up with numbers and letters. So that one has to go in a sequence. There's really no way around that. However, there is one other test that asks about words, for example, and then they define some words, for example. We can do that, at another time if they're not willing to do that. But all we need to do is indicate that there were modifications made. And all in all, at the end of it, okay, once you do the modifications, did the child comply and were they able to complete it? And did they show effort? Those are the most important things. If they showed effort and completed it with the modifications and they still got lower scores, that's a true estimate of their ability. If we did accommodations, okay, and despite the accommodations, they did not show effort, they got really frustrated and they could not complete the task, then the scores really don't reflect their true ability. Okay, I don't know if it makes sense in terms of how we, we should approach that.
Right. Thank you for expanding on that.
Yeah, definitely. I think that's very important.
With PDA kids, sometimes they want that visual, sometimes they don't want that visual. It's all about that control piece.
Yes.
Knowing that these tests are standardized, it's sometimes you're in that catch-22. So it's really nice to know that there are, I didn't know that there were accommodation modification parts built into these standardized tests. So thank you for clarifying that for me.
Yeah, definitely. And I think that would be a great conversation. These are all things I think would be great to have at the intake. Kind of like saying, maybe saying something like, can we spend, because I know my child and I know my child could have some needs that need to be met in assessment so that we have a valid, accurate assessment. Can we discuss maybe some modifications, before even the assessment starts? Because once it starts and you start doing things, it's hard to take it back because you're paying, you're in the process, you can't repeat a test, if it's, invalidated, it's, practice effects, you can't use the same test and so forth. So it could pose problems afterwards. So it really makes sense to discuss these before the testing starts, definitely.
So I've got another question that if you might have a type of personality that's more submissive, and not confrontational, or just don't feel comfortable in bringing something like that up to a practitioner, do you think it would be okay for them to maybe write their questions down? I mean, how would you feel that write their questions, just talking points that they, would like to address with them?
Definitely. Because if we all think about it, like when we go to a physician, right, for ourselves, and we really, maybe hoping for a certain medication or a certain method. But, it's kind of like hard to say like that's what we want. So for anyone, it could be, very difficult because you're sitting there with someone with their degree, and, we're considering that they know what, they're doing, and they have the ultimate word and authority on it. So it could be very difficult for the parents, for some parents to advocate for themselves or to start out these conversations. So that's why I'm hoping that, of course, that's how I train my students to be clinical psychologists, is before the intake ends, I give parents a space, and then I ask this question. And my hope is that all clinicians do that before we start assessment, is because assessment starts the following weeks, not just right away. I say, so we talked about these and things. So based on all the presenting issues, this is what we're gonna do. And then this is the goal of our assessment, is to X, Y, and Z, okay? Based on all of these things, do you agree with this? First, I asked that. Do you think that I captured everything that we talked about today? Okay. Was there anything that that I hope that you asked, but I didn't? Okay. And then is there anything, any needs, any accommodations, anything that you think your child or you might need during this assessment that we haven't maybe discussed? Okay. So I leave that last piece of 10 minutes or so just to talk about anything that, and then just provide that safe space, saying that, well, I did my part, I collected all the information that I need, but I'm sure there is something that maybe you wanted to share. So when you open that up that way, then even some of the more reserved, parents could kind of like break that, maybe that reservation, and kind of like be able to share the extra things that, they wanted to, discuss with you. So if your clinician is not asking you those questions along the way, at the very end, maybe even at the beginning, that you can say, well, I had also some, some questions and so forth. Can I ask them at the end or at the beginning? Just like you said, they could jot down and write those and give it as, talking points. And then, the clinician can read them and try to, address them in there. So, there are different ways to, approach that. But I'm hoping that, clinicians also provide that, safe space and, during the interview, so that those can be discussed before, we kind of like get started with the assessment.
Perfect.
So I have a question about that as well. So should an assessment always have an in-person intake and interview, as opposed to just sending the packet of information for the, the stack of paper for the parents to fill out?
Well, I know that there are different standards and there are different procedures, let's say, not standards, but procedures, depending on what type of clinic. But most places would have, I mean, again, these days when you say in person,
Sure.
Let's disregard the whole COVID part,
right?
Because all intakes are at this point still in person, virtual. But if we take that outside, sure. Yes, an intake, or what we call interview, needs to be face-to-face with the clinician. So the goal is to collect information from the parent and the child. So we can structure the intake in different ways. We can, what I like to do, especially for my autism evaluations, is see the family together. Whoever wants to be involved, we invite mom, dad, sibling, doesn't matter. But definitely at least one parent and the client. And then I interview them together, and I ask about all the the background history, right? Developmental, social, school, peer relationships, trauma history, so everything. And then I ask specific questions about presenting problems, which is, what are the current difficulties, right? We ask about those. And then I do a good functional assessment, which means that I ask about the frequency, severity, duration of some of the difficult, behaviors, and then try to understand the function of those behaviors. And then we kind of like put everything together. And of course, they've come in with having filled out some forms too, because without forms, we can't do anything, like consent forms, release forms, and some background forms and medical, hope they brought in some medical records, educational records, IEPs and things like that, or prior evaluation reports. And then I make sure to collect everything, make copies, get all the releases so I can contact the third party. So that was another piece that I wanted to also mention is we need to have a really good observation. So when the child comes, we can observe the relationship between the child and the parent, which could be a very important variable, okay? So that also gives us a lot of good information that we cannot collect during testing, because testing is just us and the child, but that's a foreign environment, and that doesn't give us that naturalistic piece, which is we observe the relationship between the child and the family. And then the best would be if we can go, I like to do that, go and observe the child in their natural school environment to see how they're doing there. So that's a great piece of information to integrate into assessment. And then we collect third party, which we call collateral information, which is information from doctors, the therapists that they have worked with, and other people they have worked with the child, which is very valuable information. And then, we put all that together, and at the end we say, so are we all on the same page? This is what we're doing. Is there anything else that you want me to know? Okay. So, and then that's how we, approach the assessment process, rather than just sending, forms, because we need to hear from the child and from the parent what those symptoms are, what the presenting issues are, and really what they're looking for in the evaluation. Because sometimes they're going to look for a diagnosis, sometimes they're going to look for an explanation and understanding of their child. And that's the, the other piece, that I'd like to talk about as far as, how we approach that, the assessment piece. So let me also try to see if there was anything that for the modifications that I, left out. You talked about toys and everything. And one last piece is that I want to mention is making use of reinforcers such as, edibles, meaning if the parent is okay and if, we can give it to them. Of course, always ask for parent consent for, things like allergies and stuff. But, lots of kind of using stickers, little kind of toys, anything that they would be interested in, so that we can continue to provide positive reinforcement, which of course, praise, of course, will be there, but sometimes that's not enough. So we need to pair them up with, together with those, and then to make sure to be able to keep their attention during that time as well. So yeah, so these are some of the, the accommodations or modifications that we can do to sway out of from that standardized, testing. And whatever we do, then we need to put it in our report and what we have done, how we have done it, but most importantly, how did the child respond to that? Because at the end, we could say, we did all of these things. The child then responded favorably and completed the tasks, and therefore this is valid. We have provided all of these. The child, despite all of these things, responded favorably to these tasks, but not these tasks. So for the tasks that they responded favorably, they seem to be an accurate reflection. For the ones that they did not respond favorably, then those measures, those results should be interpreted with caution. And that's how we write. So we talk about how much we believe the results of the testing are valid or not. And then that way, the other person reading this, or when we explain it in the feedback session to the parents, then we can say, well, I'm pretty confident about their cognitive skills, and this is where they are. But for attentional testing, I'm not really sure. Maybe we need to repeat that testing, in another time, because, we didn't get some good, estimate. And that's a way to kind of like, explain it back to maybe the referral physician or referring, school or the parent and so forth.
Would this be an appropriate place to talk about what to do, like, especially with pathological demand avoidance not being recognized in the DMS-5, how that kind of profile can be acknowledged in an evaluation when
Mhm.
there's not a diagnostic code for it?
Mhm. Definitely. I think that's a very timely question for that. So let's say, because we've now been talking about the testing and testing and testing. So now let me shift the focus to assessment. So testing is one part of the assessment. Testing meaning we give some forms to the parents to fill out. We look at the results of those. We do face-to-face testing, and then we look at the results of those. Like I mentioned, we collect information from other people interacting with the child. We integrate it together. We do observations in school, in the clinic, and then we integrate it. So when we put all of this information together, then that's what constitutes our assessment. Okay. So when we're doing this assessment, we need to take what I call the whole child in a strength-based approach. Okay. So this approach will focus on the child as a client and as a person, and not as pathology or psychopathology or a diagnosis or a category. Okay? And then second, we need to focus on the child's strengths, what they can do, and not only what they cannot do. And then another important piece is, coming back to now to your point, is focusing on what we call conceptualization or formulation. Conceptualization means that we take into consideration everything that would impact how they're functioning, because that's the ultimate need of the parent or the family, is to understand their child, understand why they're engaging in certain behaviors. Is it due to a diagnosis? Is it due to my parenting environment? Is it due to because they're being bullied at school? We all want to always understand each other, and same with that. We want to understand why they're engaging in certain behaviors that are not working really well for us right now and for the child. So conceptualization means that at the end of all of this evaluation, we can provide a diagnosis, okay? And the diagnosis could explain a lot of the presenting problems, okay? But sometimes a diagnosis will alone, and again, for diagnosis, we're only bound with what's in the DSM-5 or an ICD, 10 or 11, right? So we're bound with that. But as clinicians, we shouldn't really be bound only with, what we have at this moment. We should be really bound with or considering everything, which is the context, okay? So when we talk about, for example, PDA, that is not a specific subset or a profile that's not supported or integrated into the DSM-5. So, however, after we evaluate it, we've seen them in the session testing with us, we've heard about the presenting problems, we learned about the function of their behaviors, okay? So do they exit a situation because of too much demand? Do they have that high, anxiety? And when a demand is placed, they want to more control the situation, but if they can't, then they give up. Do they get more frustrated? So we more try to understand the pattern of the behavior and the underlying function, and then which circumstances exacerbate these situations. Well, school can, because school is all demand, right? So then what can we do? How can we help this child at home, in their peer relationships, and then at school? So really, in our summaries, when we write up our summaries, a good psychologist, and that's again how I teach, is we talk about the current symptoms and whether they fit into the symptoms that are indicated in the DSM and whether now they match, right? So that's the basic job. So that's what we call, the clinical kind of like impression piece, right? And then that will tell us whether we meet the diagnosis or not, okay? But that's only one part. The second part is what we call clinical formulation, which is now comes the part to explain the child. So it's almost like we're telling the story of the child. Who is this child? Why do they behave that the way they do? And then whether we would, name it as PDA or something else, because then there could be some other profiles too, okay? Then we could say that they engage in this behavior because, and this is what I have found as a clinician, this is what I have uncovered, okay? that's not captured or covered in the DSM, but we are really telling the story of the child, of course, in a clinical language. We're just saying it's happening because of this. And then you might say, well, why do we bother doing that? Well, we would need to do that because that will specifically, other than because diagnosis will, of course, open up doors for maybe, the scholarship, to treatments, to special education interventions, and so forth. I'm not minimizing that. I know that's one of the biggest things that I do as a professional and clinician. But it only explains so much. If we do not have that paired up with the formulation piece, okay, then we cannot cater the appropriate interventions and treatments to our children. We cannot help the families and parents to find out the best methods to deal with that behavior at home. We can just slap and say, like, we'll do ABA and that will take care of it, or we'll do this social skills intervention and or social stories, and that will take care of that. Because not all of the the interventions that are out there will cater to every single behavior, right? One child will need to work on safety skills. Another child will need to, maybe a teen will need to work on, sexuality, right? Another child, we need to focus on sleep and feeding because they're so young. And another one will need to, focus on academics because they have accompanying learning and ADHD problems. So not one child's variables are the same. And our job as a psychologist is to really put all of that together in our summary, where we name and just say, this is why it happens, other than the actual, criteria for diagnosis.
Yay! I'm so happy. I'm so glad that you, Gokce, are putting this out with your students, and we're going to have assessors and clinicians that understand that and get that. Mm-hmm. And they don't necessarily, check the boxes and go off of, they will go off.
Believe me, they get this spiel so much that I think it's ingrained in their head now.
Yes. And I say that, and I'm gonna even have like goosebumps. I'm a pretty assertive person. I'm not a wallflower. If when I go in and talk to somebody, I expect that they're going to be professional and they're going to listen to me. And so I personally not really encountered they're not really listening, whatever. But we do have, we've got a lot of parents that people just don't listen to them. And, or, one of the biggest thing is these kiddos mask at school. They're trying to get, special education services. They mask at school, and because the schools are not seeing, these things happen, they're like, well, we can't help you. It's not happening at school.
Very good example for that one.
We'd love to hear it, but we just, I just felt like when you got done with that, there was just like this huge, it was this crescendo, and then it was just like, oh, yay. So my mom heart and my friend heart thanks you so much that this is going forth into the universe, and helping our kiddos who struggle so much, and our families who struggle so much, and trying to get this very unknown profile recognized and supported. We would love to hear your example for that. If you'd like to share it.
Yeah. If we have a little bit of more time too. I know we hit the at 2, but and I do agree with you that this is, and I see your sign too right at the back. This is a journey, and when I talk to my families when I'm doing an evaluation, one of the most important sessions in that whole evaluation is for me the feedback. I also wanted to mention that. Feedback is the session when you're done with the report, you've written it, everything is done, that's the time to explain the results to the parents, the client, and the family. Okay, so that's the time that I'd like to kind of like share that this is not the end. This is the beginning. This is a new journey, and that's the time I'd like to instill hope, and saying that maybe so far things didn't make sense to you. Maybe so far things were really hard. I'm not promising that it's not going to be hard again. So I'm not going to kind of like sugarcoat it and say like, yeah, from now on, everything is going to be great. No. But what I'm kind of like saying is that now that we have uncovered a lot of things about your child, the rest of is, your journey is going to be, working with your child on this beautiful, beautiful journey, not without its hardships, but it's a beautiful one. So that's the time I like to kind of like, see the parents, like you said, take that deep breath and then just sigh it and give it back and say that now that I understand more, only with a diagnosis, you can't give that. You have to explain their story. And that's why I said that this is how we need to approach it. And then same with the child, we have some fabulous, great ways to explain diagnosis to children too, how we give feedback and explain them. And sometimes we even write like little stories and narratives about, other children who kind of got through that, and along with some books and things. So that I wanted to also mention that too, that being definitely a journey. So my example that I kind of like encountered this situation a little bit more specifically as it relates to, PDA and evaluation, kind of like around that, not knowing again, that's what I was going to uncover. So a client came, was 7 years old, and when the mom came, she was definitely experiencing very high stress levels. So I could see she had that high parenting stress. She had tried to get him evaluated probably around 3-4 times. 3-4 times is huge. That means you started it, you filled through the paperwork, and you all know how much it takes to do all that, taking time from school and work, and right. So, and then all she heard at the end was that your child cannot be tested because he would just flee out of the testing room. And she said he doesn't like, these closed spaces, buildings, anything that resembles doctor's offices, because he also had been like cornered in the physician's offices to do things. He had been restrained at school. So adults who are in authority figures, okay, were very much aversive to him. So having gotten all this information, and then we asked, yes, what are your needs? What would he need? What would he respond to? What do you think would help? Well, she said, her presence, helps. I said, okay, because we also have some rules about parents not being present while we're testing unless they're itty bitty and small. After 3, we want the parents to be out of the room. So we said, okay, well, your presence helps, then, we'll have you in the session. And then we talked about some rules about what not to do and what to do. So, and then what else is he interested in? Well, they had a dog, family dog, and he just loved the dog. And on his own, actually, on the first day, he wanted to share, and with mom's permission, we looked at his, phone. And we said, like, we don't want to see any other videos. We just want the dog ones. Nothing personal there. So we, found those and making sure it's showing correct ones. We started looking at those together, and it was such a fun thing. And he wanted to sit down on the floor. We sat on the floor. He liked the corners. He liked to be scooped in a corner. So we all sat in, in a corner and looked at those, videos. And then he had another area of interest that, he wanted to talk about. So we kind of like had really nice conversations that I learned a lot of things about. And then with my, doctoral students, we decided to do warm-up sessions because I knew that this was not going to be an easy testing session. So we started out with playing things like we went to the playroom and had him choose. So gave him that control. What do you want to play with? And then we said, you pick 2. I'll pick 1. So he picked the 2 and he picked first. So he had that control feeling. And then after he picked 2 and, felt good about it, then we did 1. And then he picked another 2. So just kind of like slowly also teaching him that back and forth, that we kind of like, we can do this. So slowly building that rapport. I think we completed our testing in around 7 sessions. So that's not traditional, you know. There was one session that didn't go well as planned. We said, we're done. Okay, we can just finish it. We can't force this because we're not going to get, you know, accurate results. And then there was one that he got frustrated. He started being destructive. We said, okay, well, you know, again, we're not going to continue. We'll continue at another time. But we didn't put it as like, you know, this can't be done and so forth. So we just told them, so today probably you're not feeling like doing anything here together. So we can just play or do other things in another day, rather than framing it to the child as to you can't be tested, that's not possible, that we're upset about it. So kind of like really conveying that it's okay that this is not a good day for you. Who doesn't have a good day, right?
Mm-hmm.
So we all have that right. So do they. And at the end, you know, we figured out and we did IQ measures, which nobody could measure his IQ, and we were able to do it. And he was in the average range. We knew that he was very smart. And we presented this results to the school, because school was saying, just like you said, Heather, that he was holding up well in school. At home, he's breaking down. The school is not seeing anything. Well, we gave measures to the teachers, rating forms, and they came back and they were elevated. When we went, so the parent asked us if we can sit in the IEP meeting. We went to the IEP meeting, and the school said, well, because we said we had a diagnosis and these are the patterns of behavior. And the school said, well, we don't really see it. And I said, well, this is what your teacher filled out, and these are the results. So, so they were kind of like, okay, because the results, you know, they don't lie, you just had them elevated. So that means he's struggling. So I had to explain the conceptualization, not the diagnosis. So I said, when, you know, this and this and this happens, this is how he responds, because the format is very structured in this classroom. He can kind of like go from this part to another, and he has cues and things like that. But this other classroom is not set up the same way. That's where he, you know, breaks down, and that's where you see the issues. But then most observations is in the other class where it's more structured. Okay, so we had to show them those differences, and until we really laid it out like that, and not really just focusing on he has autism, then, you know, we were able to kind of like make them kind of understand that this is a pervasive thing, not just a parenting thing, and not something that's happening at home because they were thinking that maybe there were some parenting issues and so forth.
That is such, that we hear that, we heard that all the time. And there's so many parents suffer from that, and that there's no other word for it. They suffer greatly. But it's all put on the parenting.
Exactly. So I mean, all in all, with that type of approach, it worked. If we took another shortcut approach, I don't think, you know, we would be able to finalize the assessment first. Second, we wouldn't be able to arrive to a diagnosis. That would be another failed attempt on the parent. The school would not provide the, you know, special education, you know, interventions that the child needed. They were providing things as if almost he was autistic, though. That was the interesting part. He was already getting sensory, and I'm like, if you providing all of those things, you might be sensing that he has something, but you're also saying that he doesn't have autism. So I also had to highlight that to them in the IEP meeting. I know they weren't very happy with me. That's, you know, kind of like what happens sometimes too, that they just kind of like need to see things in a different light.
Sure, absolutely. Wow, this has been such a great conversation, and you know, we thank you, Ann and I thank you very much from the bottom of our heart for taking out, you know, etching out this amount of time for us when we know you're so terribly busy.
Go ahead, Heather.
No, please go ahead.
No, I just wanted to say, you know, obviously, thank you so much. I wish I had this information about 3.5 years ago. I feel like my son's, you know, assessment and evaluation would have gone so much differently. But I just thank you because I feel like what you have shared is going to empower so many parents. Because had I had this, even having been an educator and, I was in IEP meetings and all of that, but again, it's a completely different situation, I feel like, when you're the parent.
Right.
And, I didn't know what I didn't know at the time. And so we took him to where our pediatrician, referred us to go to have the evaluation. We did not have a face-to-face. We were just given the packet of, emailed the packet of info. And this is pre-COVID. This is 3 years ago.
Yeah. Oh.
So that's not in play, is that, I filled out all the paperwork, but then knowing, when we got the schedule, okay, here's your schedule of 3 visits, and then here's the summary. I knew right away, there's no way that he's going to do anything for you for 2 and 3 hours at a time. So I did call and express that. And while they sadly gave lip service to okay, then what happened once we were there was just a completely different story, and created so much trauma for him and for myself. And so,
Exactly.
I mean, I just can't
agree.
thank you enough for, I feel like any parents that listen to this will now have the information to know what questions to ask before they even take their child in there. Because that's been one of my questions is, some of us live in smaller communities. Some people don't have the luxury of paying out of pocket to go 3 hours away or 10 hours away to find you, or someone that is willing to do an evaluation outside of this is what we always do. But, knowing how to ask those questions now and what questions to ask. And if they're set on, no, this is how we do it, that it's okay to walk away. It's okay to find somebody else. So anyway, again, I can't thank you enough that I think this is literally going to be life-changing for, parents for sure, but also the kids that are having these assessments done, because they're already so misunderstood. And then to go have to endure these assessments that at the end of the day aren't accurate anyway, because they weren't valued as who they are, and, those modifications made. So anyway, I could probably talk to you for 3 more hours about how, I just like can't tell you how thankful I am that you've taken the time to share this and that we can share it with, so many other families. It's huge.
Well, I'm very happy if it will, reach out, even we can make an impact with one family, one child, and they have a positive experience that is devoid of trauma and more added, difficulties, then that will just make me happy. And hoping that, also for other clinicians, maybe who are just starting, who are new, if, that would be helpful for them too, that's also wonderful. But it's a area that's continues to evolve, and we are learning. And I by no means not know like everything about it. With every evaluation I do, I learn something. That's another approach of mine, that with my students, after we are done with an evaluation, we sit down and we talk about what went right, what went wrong. And then we actually literally write down, what did we learn from this experience, from this one client? And then I make them do a list. And through that, of course, by supervising that, I learn, myself too. So it's a lifelong learning process. Our families learn from us some things, and then, but most importantly, we learn from the families, and most importantly, we learn from our beautiful children that we work with and evaluate. So I'm thankful for that too. And thanks for the opportunity to talk today, and hope to maybe have some others in the future as well.
Absolutely.
We would love that.
Yeah, we would.
Okay. Thank you.
Thank you so much.
All right. Thank you.
All right.
Bye.